So why do you keep 6 eggs and $10,000? Well, every time you make love to me and I'm not satisfied, I put an egg in. You look up, 50 years, 6 eggs, that's not too bad, What about the $10,000? Oh, every time I have a dozen eggs, I sell them. You get it? With 1 dozen eggs, you sell. I gave this joke in UCLA. The physicists asked me afterwards. They said, your calculations are wrong, sir. Even at 99 cents, $1, $1.29 a dozen, you can't make love that often. Anyway. So radioimmunotherapy, treatment of lymphoma. Let's see if it's going to move forward. Should go this one, right? No battery. We need battery. Radioimmunotherapy of lymphoma. Good news and bad news. This is how I can condense it. The good news is it works. It works very well. You can find it in any NCCN guidelines that they recommended for therapy. It's almost to the point of boring. Every page of the treatment manual, it's even in the MD Anderson treatment manual if they get admitted for usually 3 indications for follicular lymphoma. It's good. The other good news is insurance covers it in the US. It is very expensive, but it's covered. And Medicare patients, the older people, like myself, they get government insurance. It's covered. What's the bad news? It's almost dead because nobody uses it except centers like us. The reality of what we think it is that if it's not administered in many community centers because most of the revenue generated by the oncology clinics is generated by the administration of drugs. So if they don't administer this drug, there's no revenue generated. But it is actually quite effective therapy. It is very effective therapy, which is just why it's a shame. Let's do a quick review. It works well because lymphoma and also leukemia are very radiosensitive. They're essentially liquid tumors. They're floating around in the body. The primary target for the widely available indium and Y90 labeled antibodies is CD20. It's present on these B non-Hodgkin's lymphoma cells. As HLA-DR are the older LIM-1 drugs which are no longer available. The biodistribution of the antibody to antigen targeting is favorable. So it has to target well, and it sticks to it, and it is favorable because it goes more to the tumor, more specifically, but not on the other normal tissues. When they treat with these antibodies, there's less human anti-mouse antibody. It could be used for stem cell transplantation because it can go to the marrow and kill all these cells. And these are beta emitters. And it is compared to the other treatments, it's fairly modest toxicity. There is toxicity, but it's fairly modest. This is from the Larson-Carrasquillo review paper from Nature. Here you can see an illustration of lymphoma cells. They are the B cell types. CD20 is the main target. But there are multiple targets which could be potential targets for therapy. The same technique applies to acute myelogenous leukemia, the CD33 or CD45. You may have read about M195. It's been used with iodine, with Y90, lutetium-177. We have an ongoing trial for leukemia for using astatine, which is an alpha emitter. So aside from the lymphoma, which is the liquid tumor, and leukemia, which is the other liquid tumor, you have solid tumors. Now you hear all the time about PSMA, right? Oh, these are all the other ones. CAIX is the carbonic anhydrase, which is a part of the hypoxia mechanism. It is sensitizing the patients who have a clone of cells which are more resistant to radiation therapy. Same as the others, we have CD33 in some tumors, CD45. These are all important in developing the right antibodies to target and deliver radionuclides to these cancer-associated surface antigens. The selection of the nuclide is important. If it is not internalized, you usually don't want it to be a certain kind of metal. There are antibodies like A33 which get internalized. The receptor grabs onto it and brings it inside the cell. There are many techniques, but the one technique you do not use is just give the radionuclide labeled antibody directly. You have to have a two-step. You can use one of the very many methods which are used. Usually, the simplest way to do it is you give a cold antibody first, saturate, and it actually has its own effect on the immune system. It simulates the immune system to attack these cells. And then you give another dose, which goes to the same receptors, which has the beta emitter. And this has emissions, which have a range of a few millimeters. So it not only kills the cell which it's adjacent to, but also the bystander cells. So it can kill a significant volume of cells. That's why it's effective. But all of this is important if you give it to the right patients. The one where it's usually used for, according to the NCCN guidelines, is approved for is follicular lymphoma. Again, to review, it's 20% of the non-Hodgkin's lymphoma, usually at an older age group. They have diffuse adenopathy, very asymptomatic. Only about 20% of them have B symptoms, like fever, etc. They have a lot of marrow involvement. That's why this is a good technique, because it goes after the cells which are deep in the marrow when it's advanced. As I showed you yesterday, you can have variable FPG activity for detection. So detection is essentially pathologic and what do you call this, molecular pathology, which will show you the presence of follicular lymphoma. If it's localized, usually people get treated with radiation therapy or by observation. They can observe sometimes, as I showed you yesterday, even if advanced disease, they can give rituximab with or without chemo. And again, they have very good long-term disease-free survival, and they are quite chemosensitive. But why would we use radioimmunotherapy? The anti-CD20 antibody, which is either Bexar is tositumomab, we call it Bexar, or Y90 ibritumomab, which is called Zevalin, you know, the B and the Z, Zevalin, the anti-CD20 antibody. It improves their response in outcomes, the addition of the cold antibody to chemotherapy. So the CHOP chemotherapy, you add Rituxan, CVP, you add Rituxan. But if you add immunotherapy, it's even better. So they have done many trials back in the 90s. This is 20-year-old stuff. It's quite effective. It's good. And this is where it's usually used for and what it's approved for currently in the U.S. First-line therapy. It's good enough to be the first type of treatment to give forward, particularly for older or infirm patients. It has minimal toxicity, so you just give one infusion after you give a couple of doses of antibody. If they've already had first-line therapy, you have R-CHOP or CVP, you can give the radioimmunotherapy after induction chemo or chemoimmunotherapy, R-CHOP or this CHOP. And then you can, if they relapse, you can do subsequent therapy. And the other one here, which is not mainly indication, but it's known to be quite effective, it's also used for primary cutaneous marginal zone lymphoma. You can use it for marginal zone lymphoma. Just one injection. This is some of the data. Are you guys familiar with the NCCN? You can just access nccn.org and you register. You can follow. It's just a guideline. Not a lot of people do it. But a lot of people expend time and effort to have more uniform treatment regimens for cancer patients. And these are the network of NCI designated cancer centers in the U.S., like Anderson, like Sloan Kettering, and many others, Dana-Farber. So if you add any of these two, these are the two which are available, to either first line or second line therapy. And here is the data from the NCCN guidelines themselves. If you treat them initially in advanced follicular lymphoma, you can induce clinical and molecular remission. You can't even find evidence of it. You draw the blood, there is no trace of it. The up to 10-year follow-up, the median duration of response is 6 years. Progression-free survival is up to 11 years. 10-year progression-free survival is 40%. This is pretty good for an antibody. It's an antibody given intravenously, one go. It's pretty good. For the older patients, older than 50, advanced patients, overall response rate 87%. That's pretty good response for any. It is truly one of the best drugs. This is supported by publications in the New England Journal of Medicine. The follow-up at 31 months, progression-free survival, overall survival not yet reached at the time of publication. This is just a summary of several frontline therapies for follicular lymphoma. This is in Nature. The quality of the scholarship is outstanding. It's just a pity it's no longer as quite as popular as it should be. Kaminsky, this is Ollie Press, Leonard, Jacob Zinzani. This is the this one at the bottom is the SWOG trial, where you can see the overall survival, progression-free survival is better at 10 years. You know, follow them at 10 years from registration. Progression-free survival, 60%. Survival, nearly 80%. Median follow-up, 13 years. It takes a long time to prove the outcome of these patients. These are the things we should done with thyroid cancer, because this is long-term follow-up. Again, you aim for long-term survival for these patients. These are the success stories of cancer. Sorry, did it go forward? If you have treated these patients already with induction chemo, you follow it up. As I showed you, this is the curve for the SWOG 9111. They give CHOP and then iodine 131 radioimmunotherapy. Overall response rate, 91%. Complete response rate, nearly 70%. At 5-year follow-up, progression-free survival, 67. Overall survival, 87%. These results rival any results we have with thyroid or with prostate. It's just very successful therapy. CVP versus iodine 131, overall response rate. This is what I told you about. You add R instead of the Rituxan CVP, you do CVP versus radioimmunotherapy alone. You know, you randomize. 100 overall response rate. CR response is 93%. Overall survival 83% versus patients who could die in a year or two. First time indolent trial, the FIT trial, you randomize to Y90 or observation. Maybe it's placebo effect. Progression-free survival is very good. And 8-year progression-free survival is 41% with a radio. It's twice the rate of observe. If you observe them, half will be gone. You'll have half as many patients left at 8 years. That's just outstanding data. Yes? Yes. Sure.
Is there any study that looks at post-induction therapy with radioimmunotherapy versus other maintenance antibiotics?
Other what?
Other maintenance antibiotics.
Like Rituxan itself. Yeah, the data shows that it's better than Rituxan alone, the cold antibody. So that's why you can use it for a consolidation therapy. The problem we have is why aren't people using it? That's your question. It's a natural. Why not using it? We don't have solid data, but it's usually the first thing they tell us is they don't have access to nuclear medicine facilities. You have to have people who are familiar with administering this. but it's actually very good therapy. Uh, from what we know, a lot of our local areas, because in Anderson we only treat 20% of the cancer patients in our city. There is that's why we have a big advertising campaign nowadays, because there seems to be this theory floated around that you only need to come to ND Anderson when you have incurable disease, only for trials, which is actually wrong. We like to get patients up front because you can, as I told you, we don't get paid depending on the treatment we give. We try to do what, because our payment is fixed. So a lot of these patients don't get to us. We still do give these treatments, again, all still on therapy, but that's what happens. They say they don't have access. I think many oncologists do not want to lose the business because you make money by giving the drug. You know, the consultation is X amount, but if you give the medication, there is a cost with the medication, and they have a fee for administering the drug. But if they give them to us in nuclear medicine, and we always say we will give them back to them because we don't really like to follow these patients after we treat them, we would monitor them for hematotoxicity. So that's what happens. So that's why this guy, again, um, pre-treatment refractory low-grade transformed NHL, single therapy, long-term durable CRs. Relapse refractory low-grade transformed non-Hodgkin's lymphoma, Y90 versus the cold. This is what you were asking for. Cold versus, they are relapse. They have cold antibody. This is rituximab versus ibritumumab, 143 patients. Overall response rate, 80% versus 56%. Complete response is double. So if you cold versus the hot, you have twice as many responses, twice as many durables. I promise you I didn't ask her to ask that question. I know the slide was coming. At 44 months, yes,
Sorry, but it's only for the refractory
refractory. This is one of the relapse refractory. There are some studies on upfront studies, and they have pretty durable response also upfront. But again, the numbers are not as many as the cold because the cold is more widely used. It's anybody can give it. Any physician could actually administer Rituxan. You give it intravenously, give them a little bit of acetaminophen before. It's an outpatient therapy. It's actually quite easy because it's not labeled with radioactivity. But if it's labeled with radioactivity, it's not as difficult. The infusion is actually still quite the same. How do we treat? You pre-medicate with acetaminophen, Tylenol. You give them Benadryl, very straightforward. You anticipate the pain and some of the chills you may feel from administering rituximab. The cold is actually not that innocuous. You administer it to 50 milligrams per meter squared. We actually give it at the oncology clinic, outpatient clinic. 50 milligrams per hour. If there are no reaction, you start slow, and then you increase the infusion rate every 30 minutes to a maximum of 400 milligrams per hour. You stop the infusion if they have shortness of breath, any signs of a severe response, and you stop. You don't give the Zevalin. If they tolerate it, it's okay. If you temporarily slow it, the infusion for less severe infusion reactions. And then you can slow it down until they can give the entire dose. You give them back, bring them back a week later, give them rituximab again per protocol, and then administer Y90 within 4 hours of the second antibody infusion. You make sure you have a 22 micron low protein binding inline filter. This is all published in the package insert. You make sure that the platelet count is pretty good. You administer the Y90 over 10 minutes, make it a slow IV. We use an infusion pump, and you give it at a dose of 0.4 millicuries per kilo. In relapse or refractory patient, you give a slightly lower dose if the platelet counts is over 100 but less than 149. Try to not administer more than 32 millicuries of Y90 Zevalin dose regardless of the patient's body weight. And of course, you have to make sure you observe radiation precautions for beta. Primarily, you make sure that the line is good, because if it's infiltrated, you may get severe burns. But you can elevate it with warm compress. It actually will not be as bad as you'd think it would be. So that's how you treat. This is how, and you can retreat these patients with radioimmunotherapy. This is a patient, and I'm not discussing Rituxan 131 because you have an entire separate lecture on that. That is actually a practical thing to do because you can label it yourself. It's cheaper. It's the same Rituxan as you give IV. And I think the IAEA has a program to help you do that. Sometimes the route of the IAEA may be more effective than buying it from the drug manufacturer as we have. This patient was treated twice, 2001 and 2006. This is the baseline PET study, chain of FDG avid nodes. You can see on the fusion CT with the PET study, you can see the adenopathy. This is if you want to image during the time of infusion, you can actually see SPECT CT with SPECT CT localization of the antibody to the nodes, which you can see here. This is the post-therapy scan at 6 months. You can see it's responded both anatomically and metabolically. It is very effective therapy. Again, the Rituxan, as was asked, by itself has an effect, but if you give the hot with the cold, you can actually have a response which is very long-lasting. This was another patient, follicular, grade 2 and 3. This is, I think, an older patient, has had previous splenectomy. You can see the adenopathy is here, and the para-aortic nodal sites. You can see node, node, node. This is lymphoma. The patient has had bendamustine with Rituxan, and this is our last protocol active. It's one of the many on this active protocol where we give fludarabine bendamustine with Zevalin, and this patient was given on trial 45 millicuries. The 32 is for clinical patients. This is dose-intensive therapy, which is for this trial. We, on the trial basis, want to see its biodistribution. You want to see it go to the heart. You want to see it clear over time. That was the immediate. This is the 24-hour image, and this is the 144 hours. So it's clearing very well. It's not retained or sequestered in any part of the body. And this is the post-therapy scan at 3 months. You can see the proof is in the disappearance of the adenopathy. After that, she got a transplant, stem cell transplant, to recover the counts. The conditioning, instead of just beam, fludarabine, and bendamustine, you had Zevalin. Patient has completed the treatment, is in remission. She actually came back a couple of months ago. She's doing very well. He was taken off the study almost a year ago. So this is how you treat them. You see, you treat, and they have lymphoma and follicular lymphoma. It's not without toxicity. This is a phase 2 trial just to focus on toxicity. Even in older patients where you think it's not as toxic, you can have thrombocytopenia. It's usually hematologic. The grade 3 thrombocytopenia was 48%, and the grade 4, 7%. I work with many oncologists. They laugh at these numbers. They say, that's not too bad. Neutropenia, 32%, grade 4, 17%, no grade 3 or 4 other hematologic toxicity. You can have infections and GI toxicities in a few of these patients. It is not without toxicity, but compared to the other treatments, it is a fair comparison to say that it is slightly less toxic than the other treatments. if one wants to do this, you usually have to pair with a specific oncologist who is familiar. And in our setting, we usually like to do it in a trial setting so you can follow these patients through. The unfortunate thing is I-131 Bexar, as they have ceased production of it in the U.S. Can you still buy it in Australia? You don't know? Yeah. Zevalin is, it's like, how do I say it politely? It's not doing as well as it should. I'm not sure how long production will be. They have ceased. Our trial, the one I showed you, the case, is going to be presented at ASH, again showing how good this is in terms of stem cell transplant conditioning regimen, which is less toxic than the others. So in summary, I'm sorry, this has a spelling error, which I thought I corrected. Probably I opened the wrong set. Radioimmunotherapy is an attractive treatment for diseases NHL, non-Hodgkin's lymphoma, like and it allows targeted irradiation and has a cytotoxic effect greater than immune-mediated effects of the cold or the Rituxan antibody only. It not only provides high radiation, as I told you earlier on, has crossfire effect. It can kill neighboring malignant cells that may not even express the target CD20 antigen. This is similar to what you'd use it for I-131 Rituxan, and I think you have two separate sessions on that, on how to actually treat and how to label next week. I have a few cases. So any more questions on radiation, radioimmunotherapy? No questions? Too early? Need coffee? A few cases. I thought I'd show a few cases. The problem with these cases is you already have them in your notebook, so you probably know the answer already, right? So it's kind of like surprise birthday party, and you know it's your birthday. Follicular lymphoma, because we're in follicular lymphoma, you have a multi-compartmental adenopathy. You can see here, sometimes they don't obey the prep. You see, and sometimes you see bowel activity. This is not as prominent. You see that in metformin, right? When you patients who get metformin, they have a lot of bowel activity. But this is adenopathy, which you can see here. After treatment, you can see with our infamous radioimmunotherapy, you can see that the adenopathy, which you can see here, FDG avid, and you can see the lungs are clean and pre-treatment. And post-therapy, you have residual adenopathy, but it's really no activity there. It's like 5-point score level 1, because it's really no activity at all. It's like background activity. You don't see anything. But you have an inflammation. You can see these nodular opacities. These are the things you need to give them a call. Why? I say this because it's very important. One of our, I would call him one of my mentors, Robert Edward Coleman from Duke. He had lymphoma, and he died after chemotherapy because of infection, of sepsis. You need to call you call it inflammation. It's nothing. You gotta give them a call. Or your patient, Dr. Fayad, I think he has an active infection because they are immune suppressed. They feel kind of okay, but maybe they're just slightly off. But they could die from these infections. It could rapidly fulminate. This is the reason why I show this, because it is not a report. This is an imaging consultation. My patient had follicular lymphoma. I treated him with radioimmunotherapy with your help. What is his status? He has an active infection. You need to bring him into the clinic, do a lavage, and give him a try, and do sensitivity tests, and treat him. Because the key, and this is a very important thing I stress, why patients come to us and why they finish their treatments, instead of 6 cycles, they get the full 8 cycles, is because of the supportive care. That's our key to our success, is the supportive care. Educate the patients, blah, blah, blah. And we, the imaging people, we are the physical exam. Don't do the stethoscope thingy anymore. You have a patient who's very ill. These are like the older patients you see. Grandma just doesn't want to eat. She couldn't go to sleep. They may have an active infection, and then the next day, the old books say pneumonia is an old man's best friend. Right? They don't wake up. This is what you see. We caused it, our treatment. This is the old adage, it always happens to physicians' relatives, right? One of my good friends, she's no longer working at Anderson. She now runs her own program back in Israel. Her mom, she would only want me, Homer, gotta read my mom's scan. Okay, but she's also a radiologist who reads PET, but she's a thoracic radiologist. That's already too much information. So 63, she had CLL. I told you yesterday we described CLL, chronic lymphocytic leukemia. So they have generalized adenopathy. A lot of times they just observe them. Sometimes they treat them. Again, she has B symptoms, tiredness, weight loss, unintended. She had a UTI, they treated her. Her main complaint is she has leg pain. Physical, there's not that much, there's no increase in adenopathy. But we're the physical exam, right? Uh-oh, it died. Oh, okay, it didn't die, but she's still around actually. So this is the scan. You guys seen this before, right? A few of you. You can see this. This is the bladder. There's a big abnormal site of activity. So in CLL, you don't expect to see hot adenopathy. So you can maybe see a few spots here and there. And you certainly see something in the spleen. So it doesn't look right. When you look at the PET study and the FUSE study, you see there's a big mass in the gluteus maximus. This is the cause of the leg pain. And if you look at it, I'm sorry, is it in color? Did they put it in color? I'm sorry. Too many buttons. You can see that this is where the sacral nerve roots arise. And if you look at it very closely, you can track. I'm sorry, I don't have all the slices. It tracks the nerve roots. This is perineural involvement by malignancy. So what do? You take ultrasound and you biopsy. It comes out lymphoma. Okay? So this is a CLL in a patient, older patient, usually they are older patients, who presents with a mass causing pain, and it B-cell lymphoma. This is Richter's transformation. So in patients who have CLL and they have worsening symptoms or maybe palpable lesions, sometimes maybe she didn't feel the mass in the buttock. It's difficult to feel those things sometimes. But usually it's adenopathy in the axillary or inguinal region. So they usually become very hot. This is an older study. John, no longer with us, is back in Ireland. Was an SUV cutoff of 5 now. I think it's more like 7 because time of flight plus post-processing reconstruction. The SUVs are usually higher, between 6 or 7. And so these are patients whom the adenopathy becomes FDG avid. So then our role is to just point where the most, you have to just find the hottest node. And then they'll biopsy it. And many times, not 100%, in our few series, about 9 out of 10, you can find diffuse B-cell lymphoma. Overall sensitivity 91%, specificity 80%. Transformation to B-cell lymphoma is pretty good with high sensitivity and high negative predictive value. So this is one of the main indications why we do these scans for lymphoma patients, rule out Richter's. Well, we're not done yet. I told you about physicians, patients, relatives. They always have something more going on. There's something going on in the left chest, right chest, right? This one. It's not a node, but it's in the breast. So you do mammo, you do biopsy. There is some hyperechoic nodule, 1 cm, biopsy. You rarely give people 2 diagnoses because you don't want to bring bad news twice. It's turned out to be breast lymphoma. Breast lymphoma is rare. Less than 0.5% of lymphomas involve the breast, usually B-cell type. And secondary lymphoma, which this patient has, is usually more common. In the patients, we had the short series of breast lymphoma, which we found The mean tumor size was pretty big. It could be up to an inch, 3 centimeters, range of 1 to 5, usually palpable. Some have diffuse enlargement of the breast. Many were asymptomatic. The mammogram showed the non-calcified mass, diffuse radiopacity, increased radiopacity, and focal asymmetry in density. So it's not quite that specific. So you will need a biopsy. The sonography, they are typically irregular, hypoechoic, and hypervascular. PET-CT showed intense activity with FDG, hypermetabolic in the majority of them. And all of them actually showed a reduction in activity after starting chemotherapy. So breast lymphoma, this is not the same patient. This is an example of diffuse, and this is an example of focal. You can see it looks like a breast cancer, but breast cancers, when we do them up front, most patients they're not usually this hot unless they're triple negative. We're not done yet. So she has activity here. So it's a pituitary microadenoma. I think you know that, right? These are very avid pituitary microadenomas. So that's what can happen. CNS lymphomas are usually very hot. They don't usually happen in the pituitary, but they're usually subependymal in pattern, and they're hotter than gray matter, CNS lymphoma. Usually with CNS lymphoma, we try to image them with MR because it's easier to see leptomeningeal disease, so you're not fooled into thinking it's just confined to one site. Plus, you need to do cytology because you can have a small volume disease floating in the CSF, and you treat them with what we call the De Angelis protocol. Lisa De Angelis is, I think she is still the head of neuro-oncology at Sloan Kettering. More cases? You still up for it? 27-year-old female, distressing symptom, dark urine. And then she had jaundice, so she has liver problem. CT scan was done, portohepatis lesion. Referred to Anderson for further evaluation, and initially seen by GI Med-Onc, what do we call them, the GI Joes and Janes. Core biopsy turned out to be lymphoma. They said, phew, easy. So they sent them to us. Because this is, instead of a Klatskin's tumor, a lymphoma is pretty easy. So this is straightforward. You have adenopathy here, adenopathy around the liver, infiltrating those. You start them with ABVD chemotherapy for 2 cycles. After 2 cycles, we like to scan to see response. However, at 4 cycles of ABVD, she developed cough, dyspnea on exertion. The diffuse activity looks like a lung scan. First time you see this, what? Did the patient get MAA? Well, wait a minute. That's 140 keV. FDG is 511 keV. You shouldn't be seeing that, right? So shortness of breath, you have the PET-CT, thankfully, and you can see this diffuse, opacity over both lungs, usually in the bases or posterior, very intense. It's inflammatory. This is bleomycin toxicity. This is when you really walk across the hall and grab you got to stop it, stop the drug, okay? Bleomycin toxicity is what you think of. The patient had bronchoalveolar. You have imaging, but you need to have pathology. You want to make sure it's not an active infection. Pulmonary function test, we already know that because the patient has hard time breathing. Asymptomatic after stopping the last course of therapy, and they resumed chemotherapy without the B, without the bleomycin, for 2 more cycles. PET scan at the end of therapy, bingo, it's still cold, it's good, AVD chemotherapy. Why is this important? This is just the post-treatment, it's cleared up, the ABVD. The bleomycin toxicity is one of the main causes of death in Hodgkin's disease, treated with standard chemotherapy. So you need to find out. These are the things, this is the thing. Just because it's a PET scan, it's getting better, you have a 5-point score of so-and-so, you got to make the call. It makes a big difference for these patients. Many series, one by Dr. Kasama from Japan, who used to be one of our former fellows. And so one more. How about one more for the road? We're still early, and I have the next set, right? 39-year-old patient presenting with severe abdominal pain, multi-compartmental adenopathy, excision of a salivary gland biopsy, B-cell lymphoma. So this is, lymphoma in the abdomen, lymphoma in the spleen. The reason we want to show this is, it's like activity in the lungs. You can see this solid, almost really hyperdense deposition in both lungs. This is amyloid. Amyloidosis in the lungs can progress and cause respiratory failure, and the patient didn't die of lymphoma, but from respiratory failure from the amyloidosis. So amyloid can be hot. It could be focal in patients with multiple myeloma. This one is very diffuse. Okay, pulmonary amyloidosis could also be nodular, not just like that case. So with that, I'd like to stop. Any questions for lymphoma? Let me go to the next. Yes, ma'am. I'm sorry?
When there's a malignant transformation, the virus transformation from leukemia
Yeah.
that you showed us, so would the CT portion always be positive? Will I always see an enlarged node?
Yes, the nodes are usually all enlarged, the more typical ones, but some of the nodes would be hotter than the others. Hotter. So you'll have like a big cluster of nodes, but on the CT they kind of all look the same, and they usually try to biopsy the easiest one with the least. The trick is sometimes you need to find the hot area. Like in that patient, there's really not much adenopathy, but the buttock was one, and it could be soft tissue infiltration. And usually these patients have increasing these symptoms. Usually the CLLs, if they are on observation, they usually don't have a problem. But when they have pain, usually the old days they would do gallium, but it's not quite as specific. The painful site they would biopsy, it's still CLL. The problem is the CLL treatment is quite very different from diffuse large B-cell lymphoma. So the idea is to direct the biopsy.
If a physician oncologist asks previous CLL patients with such symptoms, could we suggest a PGPET directly before enhanced?
Before what?
Before enhanced CT?
Yes, usually you want to do it because wherever it's hot, that's when you do the diagnostic CT, so you can have a better idea not only for reference for the biopsy itself, but sometimes you may need to consolidate with therapy. That's what usually happens, and that's a good point. When we do lymphoma, what has happened in the old days meaning like 10 years ago, we would do diagnostic CT on everybody, and then they come back the next day, they do an FDG PET with low-dose CT. What happens is they get two CT scans. So one is very high dose, one is very low dose. Nowadays, because of our concern with radiation toxicity, we at the most would do one full diagnostic CT scan, neck, chest, abdomen, and pelvis, and a low-dose PET. And then the interim PET would be just a PET scan with contrast. If there is any area of residual or non-response, if we can't resolve it with the contrast-enhanced PET, we usually can, we would do a diagnostic study, but we rarely do that. Plus, I think it is not only good practice, it is also cost-saving for the patient, because then it's not, the CT scan is quite expensive, not only radiation. Plus, they have to get stuck twice. And then there's also the issue of, what do you call this thing? Allergic response. So there's an element of risk to the iodine load. And you have to be very careful. And we'll discuss that next week, I think, on contrast-enhanced CT. So for us, the workhorse has actually been FDG PET. The strangest thing is lymphoma has always been a primary referral for our service, but it has continued to be our primary source of patients because they actually rely on it. But the trick is you have to be very good in providing the consultation. The key thing is it's not just a matter of assessing response and giving contrast. The other half of that equation is to be quite aware of dealing with an immunosuppressed patient. So if you have an inflammatory process and if all else fails, we're probably the people in imaging outside of interventional who are not afraid to approach the patient and ask them, how do you feel? Do you feel bad or out of breath? Because you can see secondary muscles or accessories. Or the best way is to have alert technologists. Dr. Mack, would you like to see this patient? He doesn't look very well. We saw him last month. He was fine. His scan is good, but he looks terrible. And then you see he has an infection and you send them. So these are things which can happen. Plus, if you have patients like this, you send them for a biopsy, you do a scan. In a patient who's had biopsy near the chest or the abdomen, they do the lung windows to make sure they don't have collapsed lung or free air in the peritoneum. So this is just to remind your technologists. They're not just technologists, they're healthcare workers who deal with this. Okay? And any other questions? No extra charge. Yeah. I'm sorry? The biodistribution study. We only do that for the Bexar before, but Zeppelin, you don't have to do it. Us, we do it because it's on a protocol, because we give high dose. We check the creatinine. No. No, we don't. We just check, make sure the real function is good. And of course, if you're giving contrast, you have to make sure, and you can adjust the dose. And if the patients have had allergies in the past, you can pre-medicate them. We have a protocol for pre-treating them with if they have an allergy before we.
Good. What about the post-therapy prognosis between Hodgkin and non-Hodgkin?
When to do it? The problem?
The prognosis.
The prognosis?
Yeah.
Oh, the prognosis is very usually, if it's completely negative, then the prognosis is pretty good. We usually have a longer progression-free survival. And it varies from the type of tumor. If it's Hodgkin's, they can be cured. If it's not Hodgkin's lymphoma, maybe not. The important thing, I think, is that if it turns negative, the likelihood of a good response rate and overall survival rate is really pretty solid. And that's why we switch completely from CT to FDG, because the predictive ability of the PET scan is actually outstanding. But it's not a perfect test. There's always that 10-20% when they can have sudden recurrence, and so they need to be monitored and they need to be followed up. What do I mean by monitored? When they develop new B symptoms, they have a palpable node, they develop pain. Pain is not a good thing in an immunosuppressed patient. It could be a manifestation of something very severe. And in neurologic symptoms, because sometimes they would relapse in other areas like the CNS. So that's always consideration. We still have a role. We still, many times we do the scan because our referring physician says the symptoms I see are not good. This is unusual. I'd want to do a PET study because I think there should be a possible recurrence somewhere. I don't know where. There's smoke, you have to find the fire for me. That's what we usually do. And that's what happens. Or they do a peripheral smear, or they do a marrow biopsy because the patient has had a high risk. And if they see marrow infiltration, then they want to see if there's nodal disease. It could come in any number of ways. So even if it's negative, they still need to be followed, not with the scan, but with physical exam and blood tests.
Thank you.
Thank you. Shall we go? Detection of skeletal metastases. This is our favorite pastime in nuclear medicine. Because that's what we're good at. We do whole body imaging. We specifically, it was fortuitous because the overall manager of radiology used to be the manager of nuclear medicine. And they usually end up in that route because they take care of hybrid equipment. So they tend to be good at both anatomic and functional. This reminds me of the Puerto Rico story, right? Functional imaging. What I told you, the Puerto Rico story. But anyway, I won't say that today. But that's how they do it. I was waiting for it to advance by itself. It needs, it's tired. It has jet lag. It's working? Yeah. All right. Most common tumors. Nearly all of them are kind of split between breast, prostate, and lung. Okay? The difference is we usually don't do bone scans for lung. That's up front, I'm already telling you. But usually do it for most of these patients. And again, it's M disease. It affects prognosis because it's M disease when it's spread to the bones, and the quality of life of the patient. You have to detect it early, and it's important for treatment planning, for not only the type of systemic therapy, but you need to address perhaps local or emergent situations if they have pain, spinal cord compression if they have certain neurologic symptoms, or pain, it could be impending fracture. Okay? Oops. Detection techniques. Let's not just talk about bone scans, but also PET, also SPECT, but also plain films. Plain films are good, and CT scans are good because they detect the content of the calcium content of the bone. The bone scan, you see bone formation, it's secondary. The MRI is pretty good because it's excellent for soft tissue resolution, and you can see the marrow cavity, so you have a better assessment of the marrow extent up front. With PET, you have a whole slew of things, but the one we use the most because it's paid for and available is glycolysis. You can use amino acid, fatty acid, proliferation agents like FLT, acetate, could be choline or methionine. Receptors, you can have somatostatin receptors, FES, 5-hydroxy testosterone. These are done in patients, but these are not widely available and approved for in the US at least. You can image targets. They can express EGFR. You can use the ones we just discussed, CD20. CMET is a hepatocyte growth factor. When tumor cells like lung cancer or colon cancer, when they get that first dose of radiation or first cycle of chemotherapy, it gets stunned and makes this CMET, and it sends these cells out to the bloodstream and metastasize. Okay, children, hide. That's what it does. So there are drugs now which can address CMET. They are anti-CMET. We have an ongoing trial for lung cancer, hepatocytes. You can give them CMET after the first anti-CMET drug, after the first cycle to suppress this growth factor which sends them out. That's what CMET is. CTLA4, these are the new popular ones, PD1, programmed cell death 1. These are the immunotherapies invented by Jim Allison, one of our faculty members. Not in nuclear medicine, he's a PhD immunologist. They say he will win the Nobel Prize the next cycle around because it is actually very good for patients who have 5-year survival, becomes 20, 25 in melanoma, end-stage disease. It has very good effect in renal cell, including lymphoma, as well as some effect in a few cases for lung cancer. So there's a lot of these are now approved and used for treatment in very ill patients. For SPECT, you shouldn't forget, SPECT is a good one. People associated with PET, but I actually invest more in SPECT than PET. Why? We have a whole slew of diagnostic and therapeutic single photon emitting agents. We have I-123, I-131. Theranostic, we've had it for decades. Even, it's great. Somatostatin receptors, we have octreotide, and you can give them the lutetium therapy. Antibodies, we just talked about them, some antigens, you can prolong life. You can palliate with MIBG, sodium iodide symporter, you can treat benign disease, etc. Or you can treat bony disease for palliation for metastatic papillary thyroid cancer. We have many therapies. I mean, I was talking ahead of the slide. I'm sorry I didn't move forward. So these skeletal metastases can cause pain, what we call skeletal-related events, pathologic fractures, and sometimes severe things like cord compression. You treat them either with bisphosphonates or with radiopharmaceuticals, and that's what we're here for. Local techniques, you radiate where it hurts, we say. Sometimes you can have solitary tumors which can be removed. They could be vascular, you could ablate them, or you could embolize them with interventional techniques. You can treat these metastases with vertebroplasty or even with interventional radiofrequency ablation. That's why you want to detect them. You just don't want to detect them and do nothing about them. If you detect them, you can actually help them with various therapy, either systemic or local, and they could be emergent, such as spinal cord compression. This is our algorithm. The number one, first thing we do is bone scan. It's cheap, it's straightforward. Nuclear medicine is above and below breast in the prostate clinic. So within 15 minutes of making a call, we can give an injection for a bone scan. If you stand still long enough in our clinic, if you don't say anything, we might inject you with bone agent. It's our number one thing because it's straightforward, it's cheap, it's a great survey. When it's positive, we want to, they typically are distributed in the marrow, right? They're solitary lesions, they could be diffuse, they could be cold, and if they're negative, if they have still symptoms, we do radiography, but nowadays we rarely do the step because our gamma cameras are all equipped with CT. So we do a bone scan, we can resolve it, it's a new lesion, we do SPECT CT. So it allows us to then make the diagnosis. If we still can't do it, it can end up with MRI or CT subsequently. At any rate, if there's no metastatic disease, they go out of the loop. If there's metastatic disease, they get treated. This is a nice chapter from our book. We have kind of like a manual, multidisciplinary approach. This is just the distribution. It's mostly within the marrow, the spine, and the pelvis. And then you have, of course, obviously, the ribs and the sternum, as well as the proximal long bones. The distribution is marrow distribution. It's the milieu at which the metastatic lesions usually like to go. It's important to look at the CT. The CT allows us to qualify them as being sclerotic or lytic. And if you can see here, this permeative margin destroying the cortex of the vertebral body should be described as an interval finding. Sometimes overlying tissues, I told you I like plain films, but sometimes you don't see it. This is a patient with multiple myeloma, but on the reformat of the CT scan, you can see the permeative lesions overlying the spine, the thoracic spine. Windowing is important. If you look at the soft tissue windows, you just don't do that. You have to look at the bone windows. So you can see here, this is sclerosis. This is a response after therapy. You cannot perceive this if you're looking at the soft tissue windows. You have to preset your windows very well. So when you look at them, you can look at the studies which have been done previously for the patient. So they're very valuable. Of course, I'm assuming now that you all have a PAC system, which hopefully you get in the future. It's really a good way of getting the studies done well and quickly, very efficient. Bone scans, as you can see, not all of the hot areas are positive. This is just a lytic lesion from a very large lytic mass from a multiple myeloma. But again, MR is the modality by which you could see the true extent because you can resolve the true epidural extension, involvement of the vertebral bodies, and you need this for treatment planning. It's the true extent of the disease. Bone scans are great. They're cheap, but they're straightforward. If you have the equipment, it's very good to push for SPECT-CT because you don't want to go back if you don't have SPECT-CT. Because if you don't have SPECT-CT, you have to ask for plain films. If you don't have any room available to do the plain films, the patient may have to wait or come back another day. And then it's not enough. You still need to do the CT eventually. It's very sensitive but low specificity, particularly for lytic lesion. It's the first imaging study we do in asymptomatic patients. Patients have breast cancer. They got chemoradiation before the actual operation. You want to do a bone scan to survey. You have a patient with osteosarcoma. They have no symptoms before they do any surgery. You want to make sure it's not multifocal, et cetera, right? And if they have pain, we can still do the sites with abnormal uptake. You can do plain film to assess for the possibility of pathologic fractures. Why? If you nail and put an intramedullary rod into a patient before they break it, there will be less cost, less pain, less debilitation for the patient. So it's good to find these sites which are susceptible to pathologic fracture. We do multi-detector CT because it improves localization and for diagnosis. It's really just the way to go. We don't use the lower quality CT scans. It's just a 16 slice is plenty for us. We use all of our cameras have 16 slice. Why do we want to also detect them? Because we have calcium analog and phosphates like samarium, radium, and strontium, which we can treat palliatively or for outcome difference, which we'll discuss in a few days. So they're important for treatment. This is just to show you in a patient with osteosarcoma. Samarium has gammas, which you can image, which can show you where they localize. It helps with treatment planning. This is not yet standard. Samarium is not approved for treatment, but it can be used for pain palliation in patients who have metastatic disease. Okay? When do we perform SPECT-CT in our institution? If you have focal uptake in the initial treatment strategy to improve specificity, particularly if it's a known site of pain or there are no radiologic findings, because if you do the CT, you could get a better diagnosis. Is it fibrous dysplasia? Is it an osteoid osteoma? Could be whatever it is. If there's a new site of activity in a patient who had a previous bone scan, or a new site of known pain, and the patient has severe back pain, there's just some schmutz in the bone scan, you do SPECT-CT. Because you can determine with the CT component a more specific diagnosis. If there's extra skeletal uptake in patients with osteosarcoma or colon cancer, you get worried. Sometimes they could just be benign, like myositis ossificans. This is a benign finding. This is just area of activity in a patient with hip pain, and this is subchondral sclerosis. You can see here. These are severe degenerative changes. But without the SPECT-CT, it would be hard. You always say it could be malignant, could be benign. Patient who has breast cancer prior to operation, you see the focus. T9, I don't even think I could see it here. This is a Schmorl's node. It's a retropulsion of the pulposus into the bone. It's a benign finding. So, you call it, there's activity, it's a Schmorl's node, it's a benign finding. We can go on to surgery. Instead of there's activity in T9 vertebral body, cannot differentiate from malignancy. So now they don't have to stop the operation the following day. So you get a diagnosis right away. Now this patient has pain in the back, lower back, multifocal osseous metastasis. If you do SPECT-CT, it allows you to see the very extensive lytic lesions, which is far more threatening than what you see on the bone scan. It's multi-level lytic lesions, and on SPECT-CT you can see this, maybe get a hint that there is some extension into the epidural region, so you get in MR, so you can see the lysis and epidural extension of the tumor into the spine itself, to the lumbar spine. So this is an aid to actually deciding not only if we need to give RT, but where to give the RT. You can do a whole body SPECT-CT. You can just do, because the cameras are pretty big, you do 2 fields of view, unless they're really tall like LeBron James or something, you can do it with 2. LeBron, maybe you need 3. So you can do, but be careful. We are a victim of our own technology. You know, a bone scan, you take a sip of Diet Coke, normal, next. When you have SPECT-CT, you have to look at the CT. You have the CT component, you have to look if there's any other things. Why is this important? The most common scenario is there's some activity in the thorax, prostate cancer. You do SPECT-CT, you didn't do the lung windows. If there is a spiculated lesion, it could be a lung cancer. You might miss that. That's a level 4 miss. So just because it is not done with contrast doesn't mean you don't look at it. If you don't look at it, it doesn't exist. Nope, you got to look at it. If you do it, it is essentially diagnostic. You can make the low-dose CT sufficient for the bones, but you can also be sufficient for lungs. So these are the things. That's the most common scenario I could think of you could miss. This is a older kid who had reversoplasty. They did the resection, put it back on, flip it around, and this is the new joint and has pain. This is 2 sets of images, May, and this is August. You can see soft tissue activity here, which wasn't there before, soft tissue activity there. And you can see more activity here. It's all bad, right? And when you do the SPECT-CT, it gives you the definitive answer that this is soft tissue. These are calcified metastases from osteosarcoma. But you can tell where they are. It could be part of the planning. It could allow you to treat with palliative techniques like samarium because it has uptake. So it does a dual purpose. So this is the SPECT-CT. This is the PET-CT, sorry, not SPECT-CT. This is a PET-CT showing the FDG avidity of these tumors, because they like to do FDG prior to giving them chemotherapy. Because the bone scan, despite being sensitive, although not as specific, can tend to have a flare phenomenon. It might not be that good for assessing response. You see them because of the bone formation, but the response could be more bone formation. So when you give chemotherapy, they become more sclerotic. These metastatic or mixed lesions or lytic lesions can become more sclerotic. So we still use the FDG, particularly in a sarcoma patient like this one. MIBG, you'll have a full discussion of that. This just to illustrate that you can see bone mets prior to treatment with MIBG. Of course, it is dwarfed by this gigantic tumor over there. If you buy the newer cameras, they have improved reconstruction algorithms. They call it XSPECT or Q-SPECT. Patient with breast cancer, you can see here. You can still do a nice bone scan. There's an activity here, lesion there. The reason I show it, because now you can show what they call HD bone. This is made by one manufacturer. You can actually see the bones more clearly. What do I mean more clearly? If you compare it to the standard SPECT-CT reconstruction, they use the CT component, the soft tissue, the fat, and the bone to help reconstruct the image, so you can actually see the contour of the bone much more clearly. Right? Can you guys see that? I don't know if it projects that well, but for us, it is actually a better scan. It seems much better. It's still undergoing a fair amount of refinement. It may be slightly more sensitive than what you're used to. You have to adjust the way you read it, but it doesn't take much longer time. It's not a larger dose. It's just a reconstruction technique, which actually helps us see the bones better. Now you can see the spinous processes, right? This is the sacrum, This is the coccyx. You can see much better. It's just scary. You can see actual bone deposition. Why are we bothering? We're such great scientists, but we're lousy businessmen. We create things which make things more difficult for us sometimes. Why? We want to quantify. Not only do we localize, do they look better? Beauty can only go so much. But what is it good for? Perhaps for quantification, for assessing progression, guide changes in therapy, etc. We've done it for parathyroid adenomas. We think we can do it for bone, but bone imaging may not be the best technique for assessing response. This may be useful more for things like iodine to assess quantitatively. There are not a lot of instrumentation or software companies doing quantitation for SPECT, but there are a few left which are doing it, and this is where I think we should focus on. So if you ever buy one of these cameras, you may want to consider taking a quantitative package. But you can do fluoride. I know if you have a cyclotron, you can make sodium fluoride by the bucket. It's much cheaper than FDG. Before you have FDG, you have a lot of fluoride. The indications are similar for sodium fluoride PET. In reality, and well, I guess I'm the oldest guy. In the old days, they used to use fluoride for bone scanning before they had the metal diphosphonates, because it was what was available. But now the cameras are so much better, it came back. The problem was in the US, General Electric let their approval lapse for sodium fluoride. So the Medicare stopped paying for sodium fluoride. So I'm sighing because we had to do all this effort to show that it's a good study. But I'm telling you, MDP is pretty good. So we could not show a great outcome difference. If you have sets of patients, you randomize, they get MDP or sodium fluoride. Does it make a difference in their outcome? It's not as dramatic. It's not a big difference. It's not like parachutes. Does a parachute helpful or not? You have somebody jump without a parachute, somebody jumps with a parachute. You know what's going to happen, right? It's obvious. Unfortunately, this one is not that obvious, so it's still not approved. But if insurance will do it, and if in your country you can do it, it's really good. It is faster clearance, so you don't have to wait a couple of hours. You squirt, you inject, and you scan. At 45 minutes, in an hour, you're done. It's faster before you can even finish a movie. The effective dose is similar, but you get a higher dose exposure because you usually give a low-dose CT from head to foot, right? You have this low-dose CT. That's still a radiation dose. If you look at the exposure dose rate, it's just a higher, it's the same, almost the same, but it's slightly higher because you still need to do CT for reconstruction. The SNM practice guidelines show 5 to 10 millicuries, 45-minute uptake time. Of course, you empty the bladder, low-dose CT. Could be now 2 minutes per field, 3D time of flight with post-processing reconstruction. 2 minutes is plenty. The group with Peter Choiti at the NCI has done, I think, 37 or so patients, and they scanned it. So essentially, you need to scan between 45 minutes and an hour. There's a gradual reduction of the uptake in the ratio of the abnormal to normal bone. You don't want to wait too long, but you don't want to image too early. So this is what this is trying to show. An older series which compared SPECT and planar, you already know the answer. Fluoride PET, not PET-CT, is much higher sensitivity, but of course if you add the CT, it always improves your specificity. That's fairly straightforward, but you still need the data. And this is for high-risk prostate cancer. If you look at it in prostate and breast cancer, again, fluoride sensitivity and specificity were pretty good. better than the bone scan, and obviously fluoride PET CT is more sensitive and more accurate because you have the CT component. When you do FDG and you have sodium fluoride and FDG comparison in prostate cancer, this is from Hossein Jadvar and the group at USC. It appears that for them in their hands, sodium fluoride appears to be pretty good at detecting recurrences or metastatic disease, I'm sorry, in patients who have high risk for recurrence, okay, or have evidence of recurrence or rising PSA level. This is just to compare a bone scan and sodium fluoride. The key is to dial it back because when you look at them up front, everything is hot. Everything looks malignant. And so you need to bring back down the activity, and you can see the activities here and there, and you can even see the 2 dots here. This is a subchondral cyst. This is benign, you can see here. And the degenerative changes are easier to see. It is always helpful. We always put the digital arrows on these sites, and you can see them. This is metastatic disease in the marrow. You can see much more clearly. Even this one needs to have been dialed back down a little bit. If you compare FDG, MDP, FDG PET CT, you know, you can detect more extraskeletal disease with FDG. That's a natural because FDG does not do just can see disease outside the bones. But sometimes sodium fluoride may be necessary for calcium detection. That's why some people, like the Stanford group, like to, it's like a gin and tonic. They put a cocktail. They mix the, we don't do that because then we don't know if there's too much gin or too much tonic. We like to drink ours with a chaser. It's either fluoride and FDG, not mixing them together. It's just an opinion. But you can do it. You can have the bone scan, the FDG study, and you can see the fluoride can detect recurrences better because, again, it's more sensitive. Multi-level disease better seen. It's negative because it's prostate. You can see it here. But you can see soft tissue involvement, visceral disease better. It gets confusing, but in non-small cell lung cancer, we tell them not to do bone scans. Actually, we make an effort to stop them. It's just by, sometimes it's frustrating, but we try to tell them that because they tend to be osteolytic in non-small cell lung cancer, bone scanning is not that good. You need to do FDG. It's superior to bone scanning, even in fluoride. FDG is just much better because they're lytic lesions. That's why you don't do. It's just killed the bone scanning for lung cancer. It's all gone. So that 25%, 70% is breast, prostate. The other 30% is lung. We don't do bone scans for that. That's FDG. That's FDG. What can you do with it? If you're doing sodium fluoride, we use sodium fluoride in a trial setting to actually assess volume of what we need to treat. This is for patients who are about to undergo radium therapy. I show this because now, in the old days, it was a medieval form of torture. And I described it because I was made to do it when I was a resident. You do regions of interest. It's like watching your uncle trim his toenails. It's the most boring thing. Drawing regions of interest is something hateful. It's just not good. But with the new computer programs, one of them is this MIM, which I don't have any stock in, but we use it because it's a common platform for us to use, and the radiation oncologists use it. You can draw a region of interest about the body. It will select all the hot areas. You can eliminate the bladder and the kidneys. Bingo! You have the volume of fluoride avid malignancy. You get a guesstimate. Okay? So I say this because it's one use for fluoride, and in our study with radium, it allows us to assess those patients who are likely to have marrow failure. So patients who have very extensive disease, nearly a super scan, you have to be careful when you treat them with radium, and you can make that assessment if you don't like to use the old squint sign. I feel that this is dangerous. When do you feel that feeling? So you feel that feeling by having some data to guide you, and we think if the volume is about 12,000 or greater in terms of the volume of fluoride avid disease, it is a high risk. The pictures are always better. I've described to you a very complex process. You go to Rome, you go to what do you call that chapel? This beautiful Michelangelo painted the thing. This Cappella Sistine Chapel. In the old days, 20, 30 years ago, you have it in like 20 languages. No photo, signore, no photo. You keep yelling. Now it's a big camera with a slash on it and a phone with a slash on it. The picture is better. So if it's a super scan, you have to make sure you check the volume. If it's a few spots here and there, it's okay. If it's a bit of like a Dalmatian, still okay. But when it's a Labrador, not a good thing, right? Sorry, it's the best I could do for trying to make a boring subject more better. Why? Because you don't want to make things worse. Because we'll get the blame. We're the last one to give the treatment. And man, it's radium. They say this is dangerous stuff, right? You don't want to call. And we have seen a couple of them. We had to report it to the FDA because we were the first to discover it. It's not as innocuous as we thought. And we had to give the particulars. We did a bone marrow biopsy. It was, he had disease, but he had marrow failure. That's this patient, two of them. There are many other treatments. You have iodine 131 for metastatic thyroid cancer. You can have PSMA for metastatic prostate cancer, with beta, with lutetium, or even alpha. Fred, Dr. Giesel will talk about that, so we'll make him earn his lunch. But we're not done yet. I always ask our nuclear medicine physicians, radiology is not the enemy, it's our friend. You have to be a good consumer. You have to be like our surgeons. Our head and neck endocrine surgeons spend a month. I said, what do you want to spend a month with us? Homer, the lady who runs the service in the training program, says, I want them to be connoisseurs of imaging. I said, what do you mean? I don't want to be them like schmucks. Schmucks is like an old term, but they just don't order things because they don't know what's happening. They have to know what is involved, what are the indications, by actually being there. It's like anything else. If you're part of the process, you see the chicken, like the chicken McNuggets. The kids don't realize there was this chicken running around. Somebody had to chase them down, take off feathers, and clean them up. All this, make a vegetarian out of them, which is not a bad idea, I think. You don't know the process, but knowing MR, steer, certain things, you more uniform fat saturation, you can see better the soft tissue. Plain film, you don't have to be happy with. Am I good on time still? Yeah. My voice is telling me it's time. You can see more extensive evaluation of the marrow. This is again from the chapter. It's a great chapter. Sometimes you can enhance your ability. If you're looking for bone metastasis, you give them recombinant TSH in a thyroid cancer patient. Post TSH, you can see there's sclerotic lesion. It begins to light up. You do MRI, you can see it's a lytic lesion start. It picks it up only after recombinant TSH stimulation. Again, we'll go over this and it can happen. We have whole body MR. A few years ago, we had that meeting as ISMRM in Melbourne. The data is pretty good. Whole body MR is pretty good technique, but we don't have the amount of data we have with FDG PET-CT in assessing its long-term outcome contribution to assessing true extent of metastatic disease. PET-CT is really good at what it does, which is detecting M disease. It's actually very efficient. It's quite fast. It's pretty fast for doing the study. With the newer detectors, You can do the scan in less than 10 minutes. It's pretty good. And the newer cameras, and again, I don't have an affiliation with any of them, including my wife. She doesn't invest in these, just for transparency. And she thinks they're not good investments anyway, which is true. They're not that good. They have continuous. The movement is not step and shoot. The newer cameras move continuously. The patients, although it's like the same time, they like it when there's something happening. It's like you're in traffic, you're stuck out there. But if you're moving a little bit at a time, instead of being sitting there for 5 minutes and then you move 20 feet, sit there for 5 minutes, you know, they like that better. Whole body MR, again, be careful what you wish for. You have to read more when you have PET CT, PET MR. This takes a little bit longer than what it is. Here's the point where I tell you what I think, and if I was good at predicting the future, I would have retired a long time ago. I think, in my opinion, and this is for us, as representing my department and Department of Radiology for our institution, we were late in going to PET-MR because we are still developing our own teams. You know, we're like communists. Communists kind of don't like to add more to their plate because we get paid the same anyway. We think of it as I'm sharing this so people, when they buy their PET-MRs, they'll get their support the data, which we may or may not get, to look at it as not a whole body imaging technique, but as a regional technique. It's good for the brain. Yeah? What could you use it for? Before you interview faculty members, maybe you should see the amyloid load they have. I'm just kidding. But it is good for movement. You can stop the heart very well, right? It is good for resolution. You have the prostate, the ovaries, which we usually fail. You can see peritoneal disease. It's moving up and down, right? The lungs, the liver, small volume disease, pancreas. So I think the key for us is actually we've developed specific teams for specific diseases to refine the MR PET to optimize, to maximize not just the PET part. The PET part, we're more interested, at least for me, in using a lost skill. The old-timers like myself were brainwashed into thinking about dynamic imaging. You learn how to make a parametric image, a Patlac plot, or an image of the influx of whatever tracer there is into the tumor and how much of it goes out. The newer detectors are much better resolution, and the MR is slow. It takes a long time. So you take advantage of this supposedly weakness of MR, which in my mind is not. It's the ability to acquire high-resolution image, to do a dynamic study. So we're thinking into dynamics on the prostate, dynamics on the liver, dynamics on the heart. You know, we rarely think of the heart. We give all of this stuff we just described to you, doxorubicin, adriamycin, cardiotoxic. You know, it's a whole bunch of patients you can think of. A patient with prostate cancer, they're distraught, they have prostate cancer. Somebody with severe heart failure may not live to the end of the year. You could die, you know, but heart failure is a big deal. So that's where I think PET MR would be useful for. Will we get paid for it? I doubt it. It's a very expensive technology. One PET MR, you know, you could get a whole nuclear medicine department. You know, you can buy a couple of PET CTs, SPECT CT. For the extra stuff, you can get a bone mineral density thing. You can have a probe. You can actually treat patients without this. But I think for schmucks like us, we have to move the needle forward, because if we do it, we might be able to see where disease was not seen before. In the end, we still delude ourselves. You have a 2 centimeter lung cancer. You take a blood sample, you can see tumor cells in the blood. You can detect this in the blood. We've done PET studies on breast cancer patients, and using the circulating tumor cells as an index to assess response to therapy. We've done that 10 years ago. This is old technology. So what we see is not the true extent of the disease. The future is the systemic treatments, particularly harnessing the immune system, etc. And so that's what we need to think about. So radiography, you go back to the lowest tech, has high specificity but low sensitivity. You fall, you're canoeing in Zambia, it flips over. You don't need a PET MR, you need plain film, right? If you combine radiography with sensitivity of the bone scans, you improve it. Instead of sending the patient home, take a plain film. You can see if there's a Schmorl's node, there's a fracture. The MRI, but if you do CT, it's even better. MRI detects early metastases in the marrow. We've shown you that. You can see extension from bone, particularly soft tissue or epidural extension. You combine CT with SPECT, makes the scans faster, including SPECT. You can acquire the scan faster and the PET reconstruction, and you can, and it's better than SPECT or PET alone. And FDG, as a workhorse, can detect more lytic than blastic metastasis, as in lung cancer. Okay, with that, I'd like to stop and thank you very much for your attention. Bone mets. Ladies first. Did I label something?